Adjuvant Sunitinib in a high-risk renal cell carcinoma after nephrectomy. Definition. Sunitinib is an avascular endothelial growth factor pathway inhibitor and is an effective treatment for metastatic renal cell carcinoma. We sought to determine the efficacy and safety of sunitinib in patients with locoregional renal cell carcinoma at high risk for tumor recurrence after nephrectomy. Application MACE. Sunitinib treated patients had significantly lower scores for health-related quality of life than did those in the placebo group while they were receiving active treatment. Patients with locoregional renal cell carcinoma at higher risk for tumor recurrence after nephrectomy who were receiving adjuvant treatment with sunitinib had a longer duration of disease-free survival than did those receiving placebo.
A few years ago, we presented the results of a long-awaited adjuvant study of sunitinib versus placebo in patients with high-risk localized renal cell carcinoma. And in this study, we were able to demonstrate a 24% reduction in the risk of disease recurrence associated with 1 year of sunitinib treatment in this adjuvant setting. These were high-risk patients. These are patients with stage 3 disease or nodal involvement. And many of these patients had other high-risk features. So in our control arm, we saw a relapse rate of 50% or greater by 5 years. And we were able to increase that by an absolute improvement of 8% at 5 years. So essentially 1 in 12 patients didn't relapse who would have by taking adjuvant sunitinib. This is comparable to what we see for results in breast cancer, colon cancer, lung cancer for adjuvant therapies. Yes, the drug has toxicities and we had to dose modify, but one of the key things of our study was that we limited the dose modifications to just 1 dose reduction to 37.5. Other adjuvant studies haven't done that. And consequently, when they've lowered doses, we've seen the clinical benefits go away. So when we start at full dose, when we're able to maintain full dose, we see this even with other drugs. We believe that sunitinib in the right selected patients can be a benefit in the adjuvant setting. It's FDA approved for this indication. This is a small population and not everybody will tolerate or want it, but it's something that we should be discussing with each of our patients who have high-risk localized kidney cancer.
Pros and cons. In pros, among patients with locoregional clear cell renal cell carcinoma at higher risk for tumor recurrence after nephrectomy, the median duration of disease-free survival was significantly longer in the sunitinib group. The median duration of disease-free survival was 6.8 years in the sunitinib group and 5.6 years. At 3 years, the proportions of patients who were disease-free were 64.9% in the sunitinib group. And in cons, the survival was significantly longer in the sunitinib group than in the placebo group at a cause of a higher rate of toxic events. At the time of data cutoff, an event of disease recurrence, a second cancer, or death had occurred in 113 of 309 patients in the sunitinib group. And the most common all-cause adverse, even in the sunitinib group, were diarrhea, palmar plantar erythrodysesthesia, hypertension, fatigue, and nausea. Issue applied in Ecuador. In Ecuador, the most common carcinoma in the different subtypes of cancer is renal clear cell. Among the most important factors acquired risk as a snuff or overweight, addition, or to hereditary predisposition. Renal cell carcinoma is more common in older men, and the risk factor includes smoking and obesity. Many cases of renal carcinoma are asymptomatic. When symptoms do appear, they include pain in the side of the body or back, blood in the urine, or a lump in the abdomen. Treatment may include removal of a kidney or the affected part. Treatment options are immunotherapy, targeted molecular therapies, or localized radiation therapy. And in conclusion, among patients with locoregional clear cell renal cell carcinoma at higher risk for tumor recurrence after nephrectomy, the median duration of disease-free survival was significantly longer in the sunitinib group than in the placebo group, at a cost of a higher rate of toxic events. The safety profile in patients treated with adjuvant sunitinib revealed moderate declines in quality of life while receiving active treatment.
Sunitinib is a tyrosine kinase inhibitor that targets a number of receptors, including the vascular endothelial growth factor receptors. Currently, anti-angiogenic therapy such as sunitinib is first-line treatment for most patients with advanced renal cell carcinoma. But immune checkpoint inhibitors such as nivolumab and ipilimumab have demonstrated significant efficacy in previously treated advanced renal cell carcinoma, raising the question of whether they can be used as first-line treatment. In the open-label international phase 3 CheckMate 214 trial, 1,096 adults with treatment-naive advanced renal cell carcinoma were randomized to receive nivolumab plus ipilimumab or sunitinib. The co-primary endpoints were overall survival, progression-free survival, and the independently assessed objective response rate in patients with intermediate or poor risk as determined by the International Metastatic RCC Database Consortium prognostic score. Among 847 patients with intermediate or poor risk and a median follow-up of 25.2 months, those randomized to nivolumab plus ipilimumab had significantly improved overall survival, 75% versus 60% for sunitinib at 18 months, and a significantly improved objective response rate, 42% versus 27%. Progression-free survival was not significantly different between the groups because it did not meet the pre-specified threshold for multiplicity testing. Grade 3 or 4 treatment-related adverse events occurred less frequently with nivolumab plus ipilimumab than with sunitinib, 46% versus 63%. But more patients discontinued nivolumab plus ipilimumab due to adverse effects, 22% versus 12%. The authors conclude that in patients with intermediate and poor risk treatment-naive advanced renal cell carcinoma, overall survival and objective response rates were significantly better with nivolumab plus ipilimumab than with sunitinib. Full trial results are available at nejm.org.